Hi, Assalamu alaikum. It's me, Dr. Mohammed Kazafi, and you are watching Dr. Mohammed Kazafi Views. And right now, I picked the topic which is regarding the functional neurosurgery, and the topic name is Parkinson's disease is a neurodegenerative disorder that is most present in later life with generalized slowing of movement, bradykinesia, and at least one other symptom of resting tremors or rigidity. So, other associated features are a loss of smell, or we can say there is a sleep dysfunction, mood disorders, excessive salivation, constipation, excessive periodic limb movement in sleep. And this activity actually we are doing just to say how what is the pathophysiology of the Parkinson's disease presentation, what is the and how the diagnosis of the Parkinson's disease, and the highlights and the role of the interprofessional team in its management. So the Parkinson's disease is a neurodegenerative disorder that mostly present in later life with generalized slowing of movement, bradykinesia, and at least one other symptom of resting tremor or rigidity. Other associated features are loss of smell, sleep dysfunction, mood disorder, excessive salivation, constipation, and excessive periodic limb movement in sleep. REM behavior disorder, and it is estimated that the Parkinson's disease affect at least 1% of the population over the age of 60, and the disorder is associated with loss of dopaminergic neuron in the substantia nigra and the presence of Lewy bodies. Most cases are idiopathic, only about 10% of cases have genetic cause, and these cases are seen in young people. The disorder has a slow onset, but it is progressive, and tremor is often the first symptom and later can be associated with bradykinesia and rigidity. Postural instability is usually seen late in the disease and can seriously impact the quality of life. Also important is the presence of autonomic symptom that may precede the motor symptom in some patients, and the diagnosis in most patients is based on history and clinical presentation. SPECT scan can be performed in doubtful case or to rule out other neurological disorders. So this is the thing, but I want to mention here one thing. So as you know, the disorder has a slow onset but is progressive, and tremor is often the first symptom and later can be associated with the bradykinesia and rigidity. Postural instability is usually seen late in the disease and can seriously impact the quality of life. Also important is the presence of autonomic symptoms that may precede the motor symptom in some patients, and the diagnosis is in most patients is based on history and clinical presentation. SPECT scan can be performed in doubtful cases to rule out the neurological disorder. And this picture I presented in front of you, this is the possible early non-motor symptoms such as the loss of sense of smell and drooling of the saliva from the angle of the mouth, and the constipation and gastrointestinal problems. Mask-like facial expression means you cannot recognize any facial, even though he is happy, his smile cannot be appreciated by you. Sleep problems such as the restless leg syndrome, or he is a rest leg and the leg is constantly moving. Over the past century, our understanding of etiology of Parkinson's disease has evolved immensely, and in 1919, roughly about 105 years back, it was the first recognized that the loss of pigmentation in the substantia nigra of the midbrain in a feature of the post-mortem brain examination of patient with the Parkinson's disease. In the 1950s, it was the further understood that the pigmented neurons that are lost in the substantia nigra are dopaminergic, and it is the loss of dopamine in subcortical motor circuitry and is implicated in the mechanism of the movement disorder. Parkinson's disease is a disorder of the basal ganglia, which is composed of many other nuclei, and the stratum receive excitatory and inhibitory input from several parts of the cortex, and the key pathology is the loss of dopaminergic neuron that lead to the symptoms. The common motor related symptom you can appreciate here, such as there is the slowed movement, and you can appreciate the movement has been slowed, and the tremor while muscles are at rest, and the rigidity and the stiffness, blinking less often than usual, and trouble swallowing, an unstable posture, or you can say the walking or the gait is abnormal. So it was further understood that the pigmented neurons that are lost in the substantia nigra are dopaminergic, and it is the loss of dopamine in subcortical motor circuitry, and that is implicated in the mechanism of the movement disorder in Parkinson's disease. And it has been discovered in the 1950. Parkinson's disease is a disorder of the basal ganglia, which is composed of many other nuclei. The stratum receives excitatory and inhibitory input from several parts of the cortex, and the key pathology is the loss of dopaminergic neuron that lead to the symptoms. In this picture, you can appreciate there the stooped posture, this posture called the stooped posture, and masked face or mask-like face or masked face, and back rigidity you can appreciate in this picture, flexed elbow and wrist you can appreciate here, hand tremors you can appreciate, reduced arm swing, forward tilt of a trunk, and tremor of the legs, slightly flexed hip and the knee joint, shuffling gait, and short stabbed gait also I can say here. Actually, Parkinson's disease is the disorder of the basal ganglia, and which is composed of many other nuclei, and the stratum receive excitatory and inhibitory input from several parts of the cortex, and the key pathology is the loss of dopaminergic neuron that lead to the symptom. The cause of the Parkinson's disease has been linked to the use of the pesticide, herbicides, and proximity to the industrial plants. Some individuals have been found to develop Parkinsonian-like features after injection of 1-methyl-4-phenyl 1236 tetrahydropyridine, which is called MPTP, and this chemical accumulates in the mitochondria, and this is also research suggesting that the oxidation and the generation of free radical may be cause of the damage to the thalamic nuclei. And the genes are important at the risk of Parkinson's disease in sibling is increased if one member of the family has the disorder. These cases also tends to occur much earlier in the life. So I just want to mention here in this picture you can appreciate I just presented the genetic link and the mitochondrial involvement and the link with the pesticide and the herbicides and the proximity to the industrial plant, and especially you can understand there is the element, the injection one or they checked with the injection the name 1-methyl-4-phenyl 1236 tetrahydropyridine MPTP. This chemical accumulate in the mitochondria, and this also research suggesting that oxidation and generation of radical may be cause of damage to the thalamic nuclei. So you can appreciate in this picture where there is a motor skill symptoms and non-motor skill symptoms. Motor skill symptoms such as the bradykinesia means the slowness of the activities or movement or walk, everything considered in the bradykinesia, even though the mask-like features or mask-like face, or we can say the decreased blinking of the eye and the degradation line motor skill and the drooling of the saliva from the angle of the mouth, which cannot control, even saliva can be gathered in the mouth. And the vocal symptom, when he talked, the speech has been changed, rigidity and the postural instability, tremors and the walking or gait difficulties. So non-motor skill movements such as the decreased mentation or decreased mental or behavioral issues means you can find there is some way, and sense of smell has been lost, sweating and the melanoma could be possible, you can find, and gastrointestinal issues such as the urinary issue, weight loss and the sexual concern. Apart from that, there is a pain in the knee joint, which is very much important to understand. That's why I kept this picture for understanding. Parkinson's disease affect 1 to 2 person per 1000 at any time, and the prevalence increase with age to affect 1% of the population above 60 years, and 5 to 10% of patients have a genetic predisposition. So the incidence and prevalence of the Parkinson's disease do increase with advancing age, and the condition is more common in men than women. And if you can appreciate here in this picture, you can see there's a mask-like face, reduced arm swing, stooped posture, rigidity, flexed elbow and the wrist, resting tremor, slightly flexed hip and knee joint, and shuffling of the short step gait. In 1999, several members of an Italian family in the New Jersey area were identified as having Parkinson's disease, and the research for the genetic basis of its illness gained momentum. Studies on families with the rare autosomal dominant form of this disease led to a further breakthrough, and the primary etiology appeared to be the accumulation of alpha synuclein is the various part of the brain, primarily the substantia nigra, leading to degeneration and subsequent loss of dopamine in the basal ganglia that control muscle tone and movement. The accumulation of the alpha synuclein protein may be secondary to the genetic predisposition, such as the PARK1 mutation identified in the Contrusi kindred of New Jersey or triggered by an unknown environmental agent. There has been some recent interest in establishing an infection etiology that triggered this alpha synuclein accumulation after report that the earliest degenerative changes in Parkinson's disease appear in the mesenteric plexus on the GIT, from where it progresses up to involve the dorsal motor nucleus of the vagus nerve and the sleep center in the pons and then the midbrain. The interesting theory was addressed by patients with Parkinson's disease typically suffer from gastrointestinal motility issues and I want to say here the rapid eye movement sleep disorder, and both of which can precede the motor manifestation of Parkinson's disease for many years. Therefore, our knowledge about the etiology of Parkinson's disease evolves. It is not enough to regard this disorder as primarily caused by lack of dopamine in substantia nigra. There appear to be a darker, more extensive pathophysiology blindness or blinded. This and non-genetic cause of the alpha synuclein disposition in the brain are a subject of active research. And there are 4 types of the Parkinson's disease. One is the primary Parkinsonism, second is a dementia associated with Parkinson's, and the third one is typical Parkinsonism, and fourth one is a multiple system atrophy, or which also called MSA. When I was mentioning that the accumulation of alpha-synuclein protein may be secondary to genetic disposition, such as the Park mutation identified in the Contracy kindred of New Jersey or triggered by an unknown environmental agent, there has been some recent interest in establishing an infectious etiology that triggered this alpha-synuclein accumulation after report that the earliest degenerative changes in Parkinson's disease appears in the meninteric plexus on the GIT, from where it progresses up to involve the dorsal motor nucleus of the vagus nerve and the sleep center in the pons, and then the midbrain. So the interesting theory also addresses why patients with Parkinson's disease typically suffer from the gastrointestinal motility issues and the REM sleep disorder, both of which can precede the motor manifestation of Parkinson's disease for many years. Therefore, our knowledge about the etiology of Parkinson's disease evolves, and it is not enough to regard this disorder is primarily caused by a lack of dopamine in substantia nigra. There appears to be darker, more extensive pathophysiology behind this, and this non-genetic cause of the alpha-synuclein deposition in the brain are subject of the active research. Loss of dopamine pigmentation in the substantia nigra is visible to the naked eye in cases of the Parkinson's disease also. Parkinson's disease is characterized by the neuronal inclusion of alpha-synuclein or synuclein in the neuronal cell body, which is called the Levy bodies, and within neuronal cell process, Levi-neuritis, the combination of Levy bodies and Levi-neuritis is sometimes referred to a Levy-related pathology. The hallmark of any neurodegenerative disease is selective neuronal loss, and loss in Parkinson's disease is most marked in substantia nigra pars compacta, and it has been known for many years. However, the Levy bodies in Parkinson's disease extended well beyond the substantia nigra based on the distribution of alpha-synuclein pathology. So, Brack and co-workers have proposed an staging scheme of Parkinson's disease, and in this scheme, neuronal pathology occurs early in the dorsal motor neuron or dorsal motor nucleus of the vagus nerve in the medulla oblongata, and anterior olfactory nucleus in the olfactory bulb. As the disease progresses, locus coeruleus neuron in the pons and dopaminergic neuron in substantia nigra are affected, so pathology extended to the basal forebrain, amygdala, and the medial temporal lobe structure in the later stage, with convexity cortical area affected on the last stage. Subsequently, there have been proposals that the autonomic neuron in the peripheral nervous system may be affected by involvement of central nervous system, which has promoted recognition that the Parkinson's disease is a multi-organ disease process, not merely a disorder of central nervous system. However, it has fed that the debate on cell-to-cell transmission of unknown transmissible agent from the gut to the brain through the retrograde transmission in vagus nerve. And in this picture, you can appreciate there is a diminished substantia nigra neuron affected by the Parkinson's disease, and you can appreciate here this the dopamine can be the treatment for it, and you know that there is a tremor is a main symptom. So this picture as a small, I think, in a small collection of knowledge to present in front of you. If I want to talk about further, an an earlier feature of the Parkinson's disease is, as you know, tremor, and typically unilateral and present at rest, which is usually the reason for seeking help at a neurology clinic after using the hand, such as the pick up a book. A tremor may vanish for some minutes and only the return when the patient is distracted and resting once again. This is also, or this is so called re-emerging tremor that is typically of Parkinson's disease. Although tremor is a prominent and early symptom of Parkinson's disease, it is not always present and it is not a necessary feature of diagnosis. Slowness or bradykinesia, on the other hand, is a core feature of Parkinson's disease, and patient will notice it take them longer to do the simple tasks, and their walking is slower and their ability to respond to threat is compromised. In the clinic, patients demonstrate an inability to tap their index finger and thumb rapidly, so tap their foot rhythmically on the floor or walk steadily. It is the proper diagnostic features, or you can say the clinical examination will show these things which I mentioned just before. Rigidity is the third prominent feature of the examination, and patient appear stiff and find it difficulty to raise out of a chair without support. While walking, there is a reduced arm swing, more so on the side than the other. As Parkinson's disease typically is asymmetric at the onset, and checking muscle tone, lead pipe, or the cogwheel, rigidity can be appreciated. A combination of the bradykinesia and rigidity leads to some other characteristic feature of Parkinson's disease, such as the micrographia. Interestingly, the diminished size of the Hitler's handwriting over time leads to the retrospective diagnosis that he may have suffered from Parkinson's disease. The fourth prominent feature of Parkinson's disease is a gait disturbance. Although this is typically a late manifestation, flex posture, reduced arm swing, fascination, march, patted pass, cormia, or retropulsion, and returning an N block are people turn to describe the gait in Parkinson's disease. In advanced Parkinson's disease, patient will have trouble rising from the chair without support, and they take a small, slow step. They are unable to stop themselves from falling if pushed lightly, and they cannot turn around without taking several small steps, and they tend to freeze when faced with the certain stimuli, such as the door frame or a passerby. With experience, a neurologist can diagnose a long-suffering Parkinson's disease patient from their progress to the office chair from the waiting room. However, it has to be said that some other neurological conditions, such as normal pressure hydrocephalus, can produce a similar gait, and the gait disorder is not an early feature of Parkinson's disease but is frequently described as it is easy to recognize and snitch the diagnosis in later stages. Apart from the above four prominent features of Parkinson's disease in clinic, patients are usually asked about constipation, drooling of saliva from the angle of the mouth, mood disorder, and depression. Rapid eye movement sleep disorder, and insomnia. These subtle symptoms frequently accompany the tremor rigidity paradox of patients with Parkinson's disease and reflect the underlying alpha-synuclein deposition mediated neurodegeneration in part of the brain other than the substantia nigra. It means you can find in the other parts of the brain also. So autonomic symptoms are common in Parkinson's disease. Beside orthostatic hypotension, constipation, difficulty swallowing, urinary retention, and erectile dysfunction are common. Often these symptoms do not improve with treatment, but the depression is also a very common in Parkinson's disease. As the disease progresses, dementia with significant loss of cognitive function is common. Regarding the evaluation of patient with the Parkinson's disease, usually start with the history and physical examination geared to pick up the sign and describe above. Movement disorder clinics may employ the Unified Parkinson's Disease Rating Scales to quantify patients' mentation, behavioral mood, activities of the daily living, tremors, motor examination, and complication of therapy. There is no specific laboratory or imaging study that can help make a diagnosis of Parkinson's disease. An essential part of the evaluation of Parkinson's disease is to exclude the effect of the medications that can lead to extrapyramidal side effects and motor manifestation that are at times indistinguishable from classical Parkinson's disease. Typically, it is a traditional antipsychotic that are implied, and in these cases, the non-motor manifestation of the Parkinson's disease, such as insomnia, are not found. It is also important to exclude the neurodegenerative condition other than such as the alpha and synchronopathies such as the Lewy bodies disease and the multiple system atrophy can present with the Parkinson's disease, but have the subtle difference that distinguish them as a separate disease entity. And similarly, you can say the tauopathies such as the progressive supranuclear palsy can present with bradykinesia, rigidity, and gait disturbances. So all disease which I mentioned now have some motor manifestation of Parkinson's disease, but progressive supranuclear palsy patient will have vertical gaze paralysis on examination. Lewy body dementia will have the added feature of onset and dementia and hallucination, but multi-system atrophy will present with early onset autonomic dysfunction and pyramidal and cerebral sign. In terms of investigation, Parkinson's disease remains one of the few medical conditions where clinical examination remains sufficient for a formal diagnosis. MRI is useful in narrowing the differential and excluding other conditions that may present with the similar examination, such as a normal pressure hydrocephalus or subcortical stroke. In certain situations, a DOT scan can be used to identify the loss of dopaminergic uptake in the basal ganglia. However, the interpretation of this test can be challenging. The routine use of this test is to be discouraged because very few people can interpret these kind of challenging tests. Particularly, one of the best way of establishing a diagnosis of Parkinson's disease in patients with suggestive symptoms is a clear response to levodopa treatment. This is either short-lived or not well seen with overlapping syndrome. It is important to aware that there is a high rate of diagnostic error between Parkinson's disease and essential tremor in the community. Imaging studies are useful to exclude the bleeding, stroke, hydrocephalus, mass lesion, Wilson's disease. Lumbar puncture is done to exclude normal pressure hydrocephalus. Pharmacologically, the treatment is typically levodopa combined with carbidopa, which decrease side effect and improves central nervous system bioavailability. The dopamine agonist pramipixole or Ropinirole may be started in a younger patient and it may not be as effective as levodopa but will have fewer side effects. An anticholinergic or amantadine may be used if the predominant symptoms to be controlled in a tremor. Siligiline is often used to treat early disease and can provide mild symptom relief. Most anti-Parkinsonian medications provide good symptom control for 3 to 6 years. After this period, the disease progresses and this often unresponsive to medication. In general, younger patients should be treated more aggressively than the older people. A multidisciplinary approach to the management of Parkinson's disease is essential, and patients do much better than a structured physical therapy program geared to Parkinson's disease is employed. Then they can be taught to improve their balance and gait, improve their stability, and maintain the active life. Some unique features of this movement disorder have been exploited to advantages, and the patient do well with music therapy in physical fitness programs, cycling and boxing. Patients who cannot walk may find themselves able to dance. Depression, career fatigue, constipation, rapid eye movement sleep disorder, paranoia, and psychosis are often seen with Parkinson's disease. They can be a side effects of the medication or the part of the primary disease, and all need to be addressed. So the patient responding well to the pharmacological treatment may grow resistant with time, develop abruptly on and off motor symptom, or suffer from disabling dyskinesia as a side effect. Varying the pharmacokinetics of levodopa has been sometimes helped, such as newer formulation of delayed release levodopa or a continuous GI pump infusion form of levodopa, and the addition of other medication and balancing the timing of the medication can have a huge effect on the patient. For some patients who do not respond all the measures, then deep brain stimulation techniques are increasingly available to stabilize the balance of excitatory and inhibitory signal to the subthalamic nucleus or the globus pallidus, although patient with Parkinson's disease and on area of active progress, so the non-motor symptoms like autonomic or sensory are much harder to manage, or psychiatric are much harder to manage. Simply adding more medication to the patient's regime is not the answer because of the potential adverse reaction and the drug-drug reaction, drug-to-drug reaction. And so that's why I just want to mention here sildenafil to treat erectile dysfunction, modafinil for treat the somnolence, like the polyethylene glycol for the constipation, levodopa for the period limb movement during sleep, or I want to mention here that the methylphenidate for fatigue, dementia is managed with the cholinesterase inhibitor, depression is managed with the SSRI, psychotic symptoms has been managed with the antipsychotic or mipavenserine, or anxiety is managed with again SSRI, and the impulse behavior are managed by the cognitive behavior therapy. So the brainstem stimulation has become the surgical procedure of choice at this moment, and it does not damage the brain tissue, is reversible, and the stimulation can be altered as the disease progresses. So the deep brain stimulation involves stimulation of the STN, means substantia nigra, globus pallidus, interna, and the thalamus. However, deep brain stimulation is not complication free. It is prohibitory expensive, and it is also long-term benefit remain debatable. So more evidence indicated that the exercise can help to improve the gait, balance, and the flexibility. Unfortunately, the benefits of exercise are not sustained and the risk of fall is very, very high. That's why speech therapy may help in some patients, but definitely there has also some limitation. If you I want to say about something about the differential diagnosis here. I want to mention here the essential tremor, Huntington's chorea, dementia with Lewy bodies, progressive supranuclear palsy, acanthocytosis, or normal pressure hydrocephalus could become in the differential diagnosis for Parkinson's disease. Regarding the rate of the progression of disease may be predicted based on the following: male who have postural instability, of difficulty with gait, patient with older age at onset dementia and failure to respond to traditional dopaminergic medication tend to have early admission to nursing home and diminished survival. So individual with just tremors at the initial presentations tends to have a protracted benign course, and individual diagnosed with the disease at an older age combined with the hypokinesia rigidity tends to have a much more rapid progression of the disease, and the disorder leads to disability of some patients within 10 years, and the mortality rate of the patient with the Parkinson's disease is 3 times higher than the normal population. While treatment can improve symptoms, the quality of life is often very, very poor. Regarding the complication, I want to mention here there are dementia, laryngeal dysfunction, autonomic dysfunction, and kyphosis leading to the cardiopulmonary impairment. So sometime post-operative and the rehabilitation care is needed because all patients diagnosed with Parkinson's disease need long-term follow-up because of progressive behavior and the motor abnormalities. Slight adjustment in medication are needed in most patients. In addition, many patients develop erratic behavior like the impulsivity, severity, psychosis, paranoia, and somnolence. And here definitely we have to work like a team. In this team, in my humble opinion, the neurosurgeon, definitely neurologist, gastroenterologist, and otolaryngologist, physiotherapist, dietitian, psychiatrist, speech therapist, urologist, and a lot of other doctors needed to solve the problems regarding this patient. Actually, I just want to present here that the sildenafil may be prescribed for the erectile dysfunction. Constipation can be managed with the polyethylene glycol. Somnolence can be managed with modafinil and the methyl phenidate for the excessive fatigue. So, Parkinson's disease is the most common motor disorder in the US, and the disorder has no cure, and in progressive, the condition can present with the motor abnormality and the variety of psychiatric and autonomic problem. Almost every organ is affected by this disorder, and as the disease progresses, management can be difficult. An interprofessional team approach is the best way to manage the disorder. Beside the physician, nurse, pharmacist, social worker, and physical therapy play a vital role in the daily management of these patients. Nurses have many roles when it comes to looking after the patient with the Parkinson's disease. So this is the very important thing. But in my humble opinion, the first is the education of patient and family and encouraging them to participate in the decision regarding the treatment. In addition, nurses are often to first to spot difficulty in daily living and hence and should make the appropriate referral or recommendation if needed. Psychological support should be needed and the psychiatrist should be on board always. Some psychiatric nurses can manage these things very well, so you can avoid the shortage of the psychiatrists in any society. This is the definitely financially the planning is needed, disability application needed, and a lot of things are needed for that. So I want to present one case here as an analogy, and then I will do the short discussion, and then we will wrap up our topic here. My topic here to talk, there is a Parkinson's disease. As I mentioned, that there is a slowness of the body. This is a major thing, and I had a patient. So it was a 70-year-old right-handed male presented with the progressive and then began 5-year and these symptoms worsening right hand tremors, and that began 5 years ago. Now with the right leg and the left hand in the involvement, and he has also slowed too much. The families are complaining they are the shuffling gait with the mild memory loss over the last year, and the past medical history was he was a former smoker, 40 packs per year he has used, but definitely on examination, other examination, there is a hypophonia, and I want to say here the word finding, he had a difficulty in finding of the words, and the 5 hertz resting tremor on the right to left hand, bradykinesia, decreased amplitude of the fingertips, and cogwheel rigidity at the elbow joint, at the knee joint, and even though at the shoulder joint and the hip joint, a small shuffling gait, and definitely patient has been seen initially by the neurologist, and then neurologist sent to us, and then it was definitely, in my humble opinion, the differential diagnosis came in my mind, like the Parkinson's disease or essential tumor or generalized dystonia, multiple symptom atrophy, Lewy body dementia, neoplastic brain tumor, and the vascular cardioembolic stroke or lacunar syndrome, B12 deficiency, thiamine deficiency, Wilson disease, normal pressure, hydrocephalus. It could anything could be, but definitely the patient presented with that age, with that symptom. Our first diagnosis was the provisional diagnosis was the definitely Parkinson's disease. We did the MRI for this patient to exclude any other cause or any other problem, to establish the diagnosis, and in MRI T1 contrast we saw there is no focal abnormality, there was no mass lesion, with no and vascular territory, there was some small infarct, but and there is some volume loss of the brain, striatal gliosis, and mild hydrocephalus. So these things we found there, but there is in the CT scan, or sorry, in the MRI, we did not find anything big apart from there is very carefully when we saw, then the anterior commissure and the posterior commissure plane was little atrophied, and which is usually we planned we could do the once, because patient was not responding with the medication very well, and then our team decided to do the deep brain stimulation, because we have a team which the few people are doing, they're very good in functional neurosurgery, few people are good in spine. I am especially the member of the spine team, and I'm heading the spine in my region, and the other people are doing different things, so we are together, we are doing, and definitely we are discussing these things. So definitely we did all the laboratory work, routine labs, LFT, vitamin B12, thiamine, we have to check thiamine also, we checked levodopa trial we given to check the Parkinson's disease symptom improve or not. And definitely everything has been done in neurology, psychiatric consultations has been done. So, and if I consider this patient, in my patient's pathophysiology is like that, definitely the Parkinson's disease, synchronopathy of the unknown reason, and I must say the unknown origin, and the prominent pathological feature of the mid-stage and Lewy body degeneration in the pars compacta of the substantia nigra, and the basal ganglia are connected to the pathway and serving different functions. So the motor and we checked everything there and confirmed all the diagnosis here. So as you know that there is a normal and Parkinson's, what is the main difference here? Definitely it affects the substantia nigra, and the connection between the substantia nigra and putamen has been lost because of a lot of reasons, genetic involvement, or maybe the acquired infarction, and then the dopamine 1 and dopamine 2 inhibitory and excitatory neurons cannot work, and the imbalance has been happened, and after that the patient develop that kind of symptom which I already mentioned. So as you know, the basal ganglia thalamocortical motor circuit is a well-studied network in the Parkinson's disease, and the basal ganglia have been shown to modulate the amplitude and the velocity of the movement and to coordinate the activation and suppression of agonist and antagonist muscle group respectively. The stratum and subthalamic nuclei are the major input structure of the basal ganglia. The output is through the internal segment of the globus pallidus, and there are two major intrinsic pathway, direct and indirect pathway. In the direct pathway, dopaminergic striatal neuronal project to the GPI, which is inhibitory, and which is turn sends GABAminergic and projection to the thalamus. Therefore, the activation of the direct pathway and this inhibit the thalamus and facilitate the movement. And the indirect pathway is comprised of the GABAminergic projection with the stratum to the globus pallidus externa, and which inhibits the subthalamic nucleus, and subthalamic and the nucleus has excitatory effect on the GPI, and which is turn inhibit the thalamus. Therefore the indirect pathway suppresses movement, and the striatal dopamine excite the direct pathway and inhibit the indirect pathway, and depletion of the dopamine from the substantia nigra, which will cause the hypoactivity of direct pathway and hyperactivity of the indirect pathway. And in addition, Parkinson's disease is associated with the excessive neuronal synchronization throughout the basal ganglia and thalamocortical motor circuit, which limit the network ability to respond to change. So treatment option, definitely we already applied over this patient. We use all kind of medication, levodopa, carbidopa, which are the dopamine precursor, then entacapone such as the catechol O methyl transferase inhibitor, and dopamine agonist such as the ropinirole. We used that, but patient was not giving very promising results. Then we decided to do the deep brain stimulation of the globus pallidus or the subthalamic nucleus. So the deep brain stimulation has the advantage of being adjustable, reversible, and safe to use bilaterally, but has added cost and higher device-related complications such as the infection and skin erosion, and this requires the regular follow-up after surgery for device programming and surgery battery replacement, surgical battery replacement, and the bilateral implantation either stimulations or simultaneously or staged by week and month, and usually indicated as the most patients have bilateral symptoms. Both subthalamic nucleus and the globus pallidus reduce under tremor, rigidity, bradykinesia, gait disturbance, and the dyskinesia. But as you know, there is the subthalamic nucleus. Deep brain stimulation is associated with lower dopaminergic medication requirement compared to that of the globus pallidus, but may have a higher risk of exacerbating pre-existing mood depression or cognitive impairment contraindication. So pallidotomy lesion surgery has generally fallen out of favor because it is a permanent, non-adjustable, and has a significant complication rate when performed bilaterally. However, infection rates are less than the deep brain stimulation, and essentially no post-op care is required. So therefore pallidotomy has a role in some circumstances. Here I want to show one thing to you. This is the Parkinson's deep brain stimulation device, and you can appreciate here by this picture. And but there definitely it is inside, and it can cause this a foreign body, and the only I want to say the flaw, or I can say the disadvantage of this kind of device is only the infection, and definitely if infection happens, the patient will go in the dilemma of one problem, which is also a huge problem like a Parkinson's disease, and the patient fell into the another problem. For subthalamic nucleus, the intended target is the center of motor territory is the dorsolateral part of the nucleus. An approximate coordinate in relation to mid commissural point are lateral 10 mm, anteroposterior 3 mm, and vertical 4 mm. So I want to mention you again this subthalamic nucleus. The intended target is the center of motor territory in the dorsal lateral part of the nucleus. Approximate coordinate in relation to mid commissural point are lateral 12 mm, anteroposterior 3 mm, and vertical 4 mm. For globus pallidus, the intended target is the posterolateral motor territory of the nucleus, 3 to 4 mm from the internal capsule, approximately coordinated at lateral 17.5 mm from the third ventricle wall, AP 2 mm, and vertical 5 mm. So this T2 weighted fast and spine echo sequence provide the best visualization of the subthalamic nucleus, and I want to say for the globus pallidus. The stereotactic frame is placed. The entry point is usually at or just anterior to the coronal suture, and the trajectories should avoid any passage through the ventricular sulci or the cortical veins as visualized on gadolinium enhanced volumetric T1 weighted images, and the patient is placed in a semi-sitting position and sedated for opening and burr hole preparation. So as the stereotactic frame has been placed, I want to repeat, the entry point is usually at or just anterior to the coronal suture, and trajectories should avoid any passage through the ventricle, sulci, or cortical vein as visualized on gadolinium enhanced volumetric T1 weighted images, and the patient is placed in a semi-sitting position and sedated for opening and burr hole preparation. After opening the dura and placement of the guide tube for the micro electrode recording, and the patient is returned to fully awake state, and micro electrode are placed in a micro positioning system and placed through the guide tube. Characteristically neuronal discharge are shown for the subthalamic nuclei and the globus pallidus. So the subthalamic nuclei neuron discharge at 20 to 50 hertz, while the globus pallidus neuron have discharge rate of 60 to 100 hertz. So this is the difference, almost double of the from the globus pallidus discharge, and the subthalamic nuclei neuron discharge at only 20 to 50 hertz. So the border of nuclei are defined by the microelectrode recording. So the deep brain stimulation leads are then placed, and the globus pallidus, this inhibitory, the end of lead is typically 1 millimeter superior to the lateral border of the optic tract, and the leads are connected to the handheld pulse generator to confirm lead position. Clinically, voltage are slowly raised to monitor for threshold of adverse effect. For subthalamic nuclei, paresthesia, lemniscal pathway, posterior dysarthria, tonic facial contraction, internal capsule anterolateral or contralateral gaze deviation from the cranial nerve 3 nuclei medial may be observed above 6 volt. And for the globus pallidus, dysarthria or the facial contraction are typically elicited above 6 volt and indicative of activation of internal capsule medial to globus pallidus. And transit visual phenomena, which is called which may also occur due to the activation of the optic tract at the base of the pallidium, is too low, and arm rigidity, if present, should be reduced by test stimulation in either target. After confirmation with test stimulation, the deep brain stimulation lead are secured using a burr hole mounted anchor, and the leads are tunneled under the scalp with the closure of the incision. Placement of infraclavicular subcutaneous pulse generator is performed either immediately or as an outpatient procedure several weeks later. Some complication, definitely intracerebral hemorrhage could be. The risk of any intracerebral hemorrhage from deep brain stimulation is about only 5%, and asymptomatic hemorrhage occur in 1 to 2%, and symptomatic hemorrhage is 1 to 2% of patients. To reduce the risk of intracerebral hemorrhage, blood pressure should be controlled. The systolic blood pressure should not be over 160 during the deep brain stimulation surgery, and trajectories should be made to avoid any visible vessel and sulci over the gadolinium enhanced MRI on T1 weighted image, which I mentioned before. So this is the infection. There definitely risk of any infection from deep brain stimulation varies greatly between 2% and 10%. Strict adherence to the sterile technique is critical in reducing infection risk. Such kind of high-tech surgery where there's a lot of technology has been involved, definitely we have to take care of a lot of things. And here you can see how the patient is raising the hand and everything, and the machine is constantly monitoring it, anesthetics doing their own work. So these kind of, it can be done if you have a good learning curve. With the help of C-arm you can place simultaneously, you can appreciate, and the stereotactic frame has been placed, and with the help of, because for the localization you should know how to use the stereotaxy, and you should have some mastery in the stereotaxy. And if you are good in stereotaxy, then definitely you can do these procedure very well and accurate. This is the time of technology, and actually we use the same position like this. I mentioned it, but we cannot present our patient because we have a legal obligations. We cannot do any kind of these kind of pictures show for our personal use. So that's why I am usually taking the pictures from the internet to present my point in front of you people, and this is only the reason is that I just want to present and mention that this is the whole purpose, that I want to leave my legacy, that when I become neurosurgeon, I did something for the community of neurosurgeon and patients of neurosurgery. So if you like my video, please subscribe, like, and share this thing. Thank you so much. See you with one another topic soon. Thank you so much.